Hello, everyone. I'm thrilled to have the honor of speaking with Dr. Katie O'Brien. She's a doctor of physical therapy, and she's also a board certified clinical specialist in orthopedics. Dr. O'Brien, could you please start by introducing yourself and giving us an overview of your current role within this profession?
Yes, happy to do so. So my name is Dr. Katie O'Brien, and I am the owner of Redefine Health Education, and my company is here to help physical therapists become competent and knowledgeable in practicing in primary care roles, which means that they could be integrated into a primary care team. It also means that it can be someone, a physical therapist who is functioning in a first contact role. Oftentimes these therapists, I mean, they're kind of all over the country, but they're oftentimes positioned in rural settings where there's not appropriate or good access to other healthcare professionals, and they can be functioning in first contact roles there. So I'm the owner of that company. I'm also the education chair for the primary care special interest group of the APTA, where we are involved in advocacy efforts to help our physical therapy profession in the United States continue to advance.
That's amazing. Thank you so much for sharing. Primary care physical therapy is a concept that may be somewhat unfamiliar to many in South Korea. Could you explain what it entails? How does it differ from primary care provided by physicians, nurses, and nurse practitioners? Additionally, what is the referral process for the patient seeking primary care PT, and where are these clinics typically located?
Those are two really good questions. So I'll answer the first one. And a lot of people have different ways of describing what primary care actually means, but I'm going to use the American Academy of Family Physicians definition to describe primary care. And in a nutshell, without direct quoting, it's basically primary care is the provision of any services that would be provided by a physician and their healthcare team, which it can be a physician, it can be a nurse practitioner, it can be a psychologist, a physical therapist, anybody that is part of that initial first contact team that renders services from prevention and wellness, and this concept of annual or periodic check-ins all the way through traditional rehab. So that concept is sort of unfamiliar to a lot of physical therapists, even within the United States, because we're used to functioning on this sort of reactive model where we only respond to injuries or surgeries. But primary care encompasses everything from prevention and wellness and identifying risk factors, all the way through handling and helping manage patients with chronic conditions like diabetes and heart disease. And so the referral process for this, or let me just paint a picture of what this might look like. If
Mhm.
you were a physical therapist integrated into a primary care team, there's two primary ways that a patient could get in front of you. They could either see their physician first, and maybe it's for a completely unrelated reason, like having their blood pressure checked in or adjusting medications for that. And then they say, oh, by the way, I have been dealing with this dizziness, or I've been dealing with this back pain.
Mhm.
And then you, as the primary care therapist, are co-located in that primary care clinic. And so the primary care physician, knowing that this patient has some additional needs that would benefit from seeing a physical therapist,
Mhm.
says, hey, Dr. Albright, we've got this patient for you. Can you come in and meet this patient and give them an assessment? And that is initial assessment is just a way to meet the patient and get engaged with them, but also to ensure that they understand that they're not just being passed off with a referral. Because
Sure.
oftentimes what happens in these environments is a patient might be given a referral to a specialist or to a physical
Mhm.
therapist. And, there's only a small percentage of those individuals that actually follow through with the next step.
Mhm.
By positioning a physical therapist inside of the primary care team, that gives better, earlier, more accurate access to care and care navigation than it would if it was just by the referral pattern. So it can work like that. It can also work in a direct triage type situation where a patient might call in to the primary care clinic, or they might go to the online booking system and they might say, hey, I have this new knee injury. I need to see my doctor. And then they might be given the option to see the physical therapist instead.
Okay.
And the advantage to that would be the patient is able to sort of get this quicker and more accurate diagnosis and trajectory for their plan of care really early on. It also helps to prevent unnecessary diagnostic studies like x-rays or blood levels that may or may not be indicated in those time frames. So as far as actual referrals, when it happens and you're not in the same clinic, a physical therapist in the United States, in most states, direct access is allowed, where a patient can see a physical therapist without needing an order from a physician. There are some limitations to that to a certain degree, but for the most part, this is workable, and you can still do that, and you can still function in this primary care holistic sort of management mindset without needing to be in the same office as a physician.
Perfect. Thank you so much for the answer. So I think you dealt, I guess the whole picture of how physical therapists can work as a primary care physical therapist. One was working actually within the primary care team where the physiatrist is in the clinic. Second is being in the same building, but being just directed to the physical therapist directly rather than seeing a physician. Third is being referred to a clinic, which most of the states in the United States has direct access. Is that correct?
That's right.
So let's say for the first case where you are actually in the primary care team and the physician would just send your patient to a physical therapist, how would the patient be billed for their procedure? Because me not being a primary care PT, not really have that concept of billing because we're very limited on therapeutic activity, therapeutic exercises, and neuromuscular re-education. So if there's some way you can guide us through in order to help bill the patient so that we can be credited on what we do, that'll be great.
Yeah, I think that this is something that I can only speak to the United States because it's so different from insurance to insurance. It's
Sure.
so different from self-pay models, maybe combined with insurance, which we call hybrid payment model. And it's so different from one institution or one clinic to the next or one state to the next.
Right.
So it's very, very different, but I can tell you what some of the clinics are currently doing. So in the and this is excluding, military and federal programs. So in the hospital systems that I know that have physical therapists integrated into primary care teams, one way that they've been able to bill for their services is they actually function in this warm handoff model with the physician, where the physician already has a note open.
Okay.
And if they do any procedures, their additional procedures, like let's say if you do have a patient with dizziness or BPPV and you do a canalith repositioning, they'll charge for the canalith repositioning incident to the physician's note. So there are advantages and disadvantages to that. The advantages are it makes it a little bit simpler when it comes to, physical therapy requires all of these prior authorizations and copays and additional things that patients coming into primary care might not be aware of.
Right.
So it makes that component a little bit simpler, but it makes enduring care a little bit more challenging because if you bill incident to a physician, that entire plan of care then falls under the physician's NPI number. So other clinics are doing it in such a way that they have like a hybrid model where maybe there are certain patients that come in that have a certain type of insurance that doesn't require pre-authorization and doesn't require, all of this extra stuff just to be able to see a patient. And they might actually just bill traditional PT codes. So they'll bill a PT evaluation plus, maybe if they do a little exercise and a little manual therapy, they might just do that with all their traditional PT codes. They might have another patient with a similar excuse me, with a different insurance plan who that does require all of this stuff.
Uh-huh.
And then some of these organizations are just taking those patients and seeing them as a non-revenue generating service where they actually don't bill for anything,
Hmm.
but they have the patient follow up with them in the PT clinic since
Okay.
they've established that first connection and they know that the patient is going to continue with them. They
Hmm.
have the patient follow through with them in the PT clinic, whereas if they had never seen that patient in primary care,
Hmm.
that patient might have never even come to physical therapy to begin with.
Hmm.
So it's not a direct and upstream revenue generator,
Hmm.
but it's a downstream revenue generator because you're acquiring more patients over time.
Okay.
Um, so there's a lot of battles to be won with the billing aspect, but it
Hmm.
should it shouldn't in and of itself be a limitation or a barrier. There are ways to work with it.
Perfect. That's a really good answer to my question. Thank you so much for taking the time to think about it.